So we're not going to do the quiz today because of, the Canvas thing, but we'll be doing it at another time and we'll work together on what the time will be in order to get your 5 quizzes in that you need for your KGA, okay? It could be next week, the following week. We'll figure out what works. Maybe week 9, we can throw it in because there's no quiz there. But we'll work together and figure it out what works for both of us. So tonight we're going to be doing respiratory and cardiac. It's probably the gist of everything. If you can't breathe and your heart don't work, nothing else matters. So it's important. It's pretty intense. It's actually a pretty long lecture. But I think between the lecture and the cahoots, I think you're covered very, very adequately to understand. And if you can listen as I talk and try to break it down easy for you, I think we're going to get through it. Most students are scared with the cardiac. So I'm going to try to make it easy. It's actually my favoriteest of all areas in pediatric nursing. I love cardiac ICU. I love open heart surgery. I just get it. I can see the heart in my head. So I'm trying to convey that to you so that you can do the same. So remember, there's a discussion question due, and there is your first case study. Remember, you've got to read it all. You can't just go to the questions and try to answer because it's not going to work that way. So try to do your best because the case studies do help you with that thinking. So we're going to be starting out with respiratory, then we're going to be doing a cahoots, then we're going to do cardiac and do a cahoots. Anybody with any questions at all? Okay. Again, remember, anybody late today, I'm not counting your late as any time off attendance because of what's been going on. So respiratory and cardiac, they're connected, right? The heart beats, so it takes oxygen to the body, and the lungs provides that oxygen. So let's talk about first the respiratory. There's 2 components of the respiratory system. We've got the upper respiratory, which is your oropharynx, which is neck up, which means tonsils, adenoids, ears. This is epiglottis. This is anything with inflammation of the upper airway. Then you have the lower respiratory, which when we talk about infections, we think mostly pneumonia. Also remember asthma is air trapping in the lungs. So it's in the lower respiratory tract and you can't get it out. That's why there's expiratory wheezing. So most upper respiratory infections are a virus. They're not bacteria. And with viruses, there's usually pretty good fever. So most parents are like, oh, why don't you give me an antibiotic? Well, the antibiotic doesn't work on viruses. And usually upper respiratories, 90% are a virus. So we don't go directly into giving it. Now here's a picture on RSV. You've all heard about it. I mean, RSV for you and me is a common cold. But when we talk about infants, we label it with a name because it tells you what the symptoms are. When you're an infant, you are an obligatory nose breather. That means you use your nose to breathe, not your mouth. And then what you do when you eat, you suck, swallow, and breathe. So with RSV, your nose gets clogged up with mucus. So it lends to respiratory distress. Plus, there's a little fever, which makes them feel bad. Usually it's like below 101, just enough to make them feel a little bit miserable. Okay. In infants, we're going to treat it symptomatically. It's a virus. What are the treatments for viruses? Rest, fluids, antipyretics. Symptomatic, rest, fluids, antipyretics. If it's a bacteria, we're going to add on to their antibiotics. Now, children, when they're born, you're born with mommy's immune system. And within 3 months, about after 3 months, that immune system tends to weaken and goes away. And then the own baby's immune system has to take over. We give immunizations 2, 4, 6 months, 12 months, 18, 14, 24 months. I mean, we're giving as much immunizations as quick as we can in order to protect these children because moms is going away. So in the first 3 months, you really shouldn't see a sick baby. And if you do, it's really a big red flag warning. That 3 to 6 months, we know children are going to start to get sick. Mommy's immune system's wearing off. The baby needs to get sick to get its own antigens and antibodies, made to prevent them from getting that illness again. As we get into toddler and preschoolers, now we're exchanging all of our illnesses because we know when you're a toddler preschooler, explore the world in your mouth, you're swapping spit and daycare, school, toys, and everything all day long. And yes, viral infections go off the roof. Is it a bad thing? Well, not really, because by the time they get into school, they've already had all these type of diseases, right? So we want them to get it. Once they get older, usually the viral illnesses, we've had them all the time. Our bodies made all these antigens. So it's usually then it turns into more bacterial illnesses that we're going to get. And it's basically immunity increases with age. It makes sense. Immunizations, getting the disease, making your own antigens and antibodies. Now, one of the big common infections is otitis media, which means an inflammation of the middle ear. One of the biggest things that you see with it, with a child, their first thing they're going to complain of, pain. And usually they're holding it and crying it, and it's miserable, okay? What happens with otitis media? You've got these eustachian tubes. They're short and wide open, and fluid can go up in there. We know mucus goes from where there's a bunch of it, it wants to escape and like go somewhere else. So from highest resistance to least resistance, it's going to go into the ears and it creates all these infections. So how do we take care of these children? We can either give antibiotics because your whole oropharynx is full of staph. So it's a bacteria. You need an antibiotic. Now, you get a child, nursing care. They come in, they're with otitis media, as evidenced by their ear pain. What is your priority care? It's the pain. Because the antibiotics, you can give a dose now, but it's not going to work for a day. So you want to help that child feel better. Give that pain medicine, that antipyretic, that help that inflammation. Because why? What do children do when fever's down, pain is gone? They start drinking and eating, which is what we need to do for this. Any child sick, what are you going to see? Fever, earache, upper respiratory, just not feel good. These are what we see. In earaches, it's the pain, which is your priority to treat. We might see fever. With fevers, these kids stop eating. They just don't feel good. So one of the first things that we need to treat is for these children is that fever or pain, that antipyretic, that acetaminophen, that ibuprofen, whatever they're allowed to have, give it because that fever will come down, the pain will go away, and guess what? They start drinking, thinning secretions. They're not going to go up into the ear now. So that's what we want. All that mucus in ear, you're going to see it with that cough. It's all that extra rhonchi in there. Nose is all stuffed up. The mucus is going in the ears, and you're going to hear rhonchi and all referred sounds also too. Our goal, well, you want to take care of the pain, make them breathe easier, and we want to keep the hydration, nutrition up. So with children, care management, first thing, treat pain, treat fever, and the rest all just falls into suit, doesn't it? Once they feel better, they're going to eat. They're going to do everything that you want, hydrate. Now, infectious mononucleosis. This is the kissing disease. We've heard of this before. It's not a big deal. Well, it can be. Now, mononucleosis is a Epstein-Barr-like virus. Epstein-Barr is one of those viruses that's like chronic fatigue syndrome. That's what the Epstein-Barr that they think about it. So what would you see with mono? What's the presentation? Well, it's caused by an Epstein-Barr virus, so going to have the fatigue, all right? But, and the fever. But with mono, it's a sore throat and flu-like body symptoms, all over swollen glands, just feeling horrible, rash, all of these things. So this child goes to the doctor, and the doctor does a strep test, they do a flu test, they do a culture, they do everything, and everything's negative. So they send him home on treatment. What sort of treatment are we going to give? Well, it's a virus. Rest, fluids, antipyretics, right? 3 days later, the kid's still sick, still sore throat, feel horrible. And they go back to the doctor. And the doctor says, I don't know why, but let's start antibiotics just to be sure. Maybe I'm missing something. 3 days later, they're in my ER. And now they're saying, I don't know what's going on. The doctor doesn't know what to do. We're on antibiotics. The throat still hurts. He's still fatigued, feels miserable. What do we do? With all those symptoms and all that, and I'm telling you, it always is that sort of outcome that you see with mono. You know that you're going to do a blood test. Why are we going to do a blood test on a child who's doing with these symptoms? What are we trying to rule out? Well, what does a simple CBC tell us? Is it a virus? Is it a bacteria? White count is elevated, it's a bacteria. So if that's what it is, we treat with a different antibiotics. But if it's still a virus, it's still symptomatic treatment, rest, antipyretics, and fluids, right? Now, the other thing we're going to do because of the symptoms is what we call a monospot test. And that's going to see if they have mononucleosis. Now, all right, now we know what's going on. It takes time to go away, a couple weeks. One of the big things about mononucleosis is, yes, you need the fluids and the rest and antipyretics and all that, but your lymph nodes swell up, in particularly the spleen and the liver. They're like big balloons. And the thing is, if you hit your belly hard, that balloon can burst. So you need to avoid contact sports, no PE until cleared by the physician. Now, would you like to hear a story about infectious mononucleosis and a little 9-year-old boy and his father who came in on a Saturday? So the little boy came in on a Saturday with dad, all these symptoms. We did a CBC, it was negative, viral. We did monospot, positive. The doctor was great, one of the best physicians we had. He gave him great discharge instructions. And I followed up with, the same great instructions and gave him a copy of it to go home. So really emphasizing no contact sports, please protect that belly. 1 week later, I am the primary RN in charge of trauma. Anything that walks in the door, I'm the primary. I'm in charge. I have to chart. I have to make sure all the disciplines, everything's there. I'm the one who makes sure that child is safe. I get a call, 9-year-old on an ATV out in the Everglades, fell off, coming in on a copter. It was this boy. He came in dead on arrival. So mononucleosis, kissing disease, no big deal? It can be, and that's my point. So bronchitis, this is all up here, trachea and bronchus, okay? It's inflammation, itis. This is probably the most annoying of all upper respiratory. It is a dry, hacking cough, non-productive, and it's worse at night. Usually no fever. So it's usually a virus. How do we treat it? Symptomatically, we're going to give antipyretics, fluids, and rest. And the other thing we do with bronchitis, because it's a dry upper respiratory, we give a little bit of humidity, whether a cool mist, and the parent many times sitting on their lap, blowing it in the child's face. Sometimes they can put it in the bed on a tent, but usually kids don't tolerate that. And then the other thing we do is some cough suppressants, but make sure if you are trying to get stuff up, if there's there to come up, you don't want to suppress the cough. If it's dry, nothing coming, you want to suppress it because your ribs start to hurt, you're coughing so much. Now, croup. You've all heard of the barking seal, right? That's what this is. It is a laryngeal tracheal bronchitis. So it's the larynx, the trachea, and the bronchus are all swollen. It is due from the H influenza type virus, okay? That's one of the HIB that we give the vaccinations for. That's what this is important to prevent. This is most common of all of them. It is usually a virus that causes it. It's usually they've had an upper respiratory, so they've had that little bit of, inflammation there. And then all of a sudden, the swelling gets more. Now, when your upper airway, you can't get air in. So it's inspiratory stridor, okay? Because this is all swollen. I can't get it in. So it is inspiratory. And of course, all the signs of respiratory, substernal retractions, and that beautiful little cough. And we know if we don't treat croup, this inability to get an air in can lead to respiratory distress and death. Another thing that can happen if we don't treat croup, then it can turn into acute epiglottitis. So this is all upper airway again. So it's inspiratory problem. The epiglottis is a leaf-like structure that covers the trachea when you swallow. So you don't aspirate any fluids into your lungs. Well, in acute epiglottitis, that epiglottis is covering the trachea and no air can get into the lungs. I can't breathe. What are you going to see? This is a child who can't cough. Okay, he can't get air in. He's getting hypoxic, agitated, restless. He can't swallow, so he's drooling. This is a big sign of it, drooling. And then if he tries to talk, because the back of that throat is so swollen on them, okay? They are sitting in that tripod position, like an elderly, man or woman with COPD trying to breathe. And of course, all the retractions that go along with it. So you get a child, a kid in, you get them into your area, and you're in charge. What is your responsibility? This is no airway. This child does not have an airway. So you need to get someone to get it quick, get your intubation cart or tray, whatever, or a trach tray, all at the bedside. Because without an airway, nothing else matters, right? So just get that airway open, sitting them way up high. They're restless, they're agitated, they're scared. High Fowlers. Let mom, dad, wherever they want to sit. I've had children sit on the floor in a chair. I don't care, as long as they are quiet and not restless. I want to decrease oxygen demands. And then it's nebulized epinephrine. It's called racemic epi aerosols. And the epinephrine goes directly into the place which is swollen, helps decrease it, and allows that a little bit of space for the child to get air into the lungs. Also, they'll give steroids. IV steroids are the most effective. So we try to do an IV on this restless, agitated child. Very sick kid. Now, RSV, I've mentioned it. I told you it's infants. I told you they don't have enough room in their nose just to suck, swallow, and breathe. And then you put mucus in there. Now they're in really big trouble, right? Well, what if they had a cardiac condition, or they were premature and they were on oxygen, or they had other conditions, immunosuppressed, that little bit of extra work that they need to do is not good for them. So we want to prevent RSV in infants. Now, we're only concerned the first 1 year of life with RSV and immunizations. We will give every month one immunization called Synagis or Pavizumab to this child. First year only, from early winter to early spring. This is when we give it only. So after that, RSV is a cold, the child can handle it, can blow their nose better, et cetera, et cetera. Again, RSV is all about, the nursing care is to keep the nose open, suction it if before they feed, or tube feeding, or IV, or whatever they need. Now, many children have sleep apnea, chronic sore throats, and they need to get rid of their tonsils. Most most tonsils today are done on an outpatient. They come in, have the surgery, and go home. So you need to know how to teach this child and the parents post-op care. So what are we going to teach them? I mean, preoperatively, you come in, they're NPO, they have surgery. Postoperatively, number one, they come out of the OR, they're still half asleep. How do you maintain an airway on a child who just had their throat operation on? Well, it's side lying. And the reason is the blood, if they start to bleed, can come out the side, okay? Because the biggest concern post-op tonsils or adenoids is bleeding, okay? So everything we do is to prevent it. No irritating high season food. It irritates it, it burns it, can make it bleed. No gargling, no toothbrushing. Their breath stinks. So many children just want to brush and get that stink out. There's two big scabs that are left in the back of the throat. They cut out the tonsils, cauterize the areas, and there's a scab left. That's what a tonsils is. It's pretty intense when you think about it that way. So no straws in the mouth. No, as nurses, don't suction, no tongue depressors, nothing in the mouth, okay? Older children will use an ice collar that they put on their neck, and it works. It's nice. Young kids will not tolerate ice on their necks. Other things that older kids might do is chew gums. Think about where the eustachian tubes are. They're right there where the surgery was done. And a lot of times they get blocked and creates a lot of ear pain. What do you do if you're in an airplane going up and your ears start popping and hurting? If you chew gum, it won't happen, right? Same concept for TNAs or tonsils. Have an older child chew gum. It'll help eliminate that pain in the ears, okay? Know that these kids can go back to doing their own things in about a week or two, and they do need to be on bed rest. And if they have like chronic, it continues on, fevers, coughs, earaches, more than 10 days, something is going on, they need care. It could be an infection in there. Now, let me tell you about tonsils. I'll tell you another story. 7-year-old little girl had just come from the ENT. She had her first OR visit, 1 week post-op. On the way home in the car, she vomited and it was bright red blood. So they brought her to the ER. I'm the trauma nurse, I'm the triage nurse on duty. So I bring her in, I look at her, and the parents are carrying her. And she looks a little bit lethargic. She vomits a clot, like I call it a liver clot, because it was quite big and filled up one of those pink basins about this much full of blood. She went very lethargic. So I literally picked her up and ran into the trauma room where she was going into hemovolemic shock. I gave her a whole 1 liter of fluid, 7-year-old. Her heart rate was 160. Her blood pressure was 70/40. 1 liter of fluid. How do you treat this persistent bleeding? She had to go back to the OR, and ENT had to recauterize the area. That's the biggest concern with tonsils. Now, pneumonias. You can inhale it or you can have an organism. There's different type of pneumonias or aspiration. So bacterial pneumonia, you treat with antibiotics. Viral pneumonia, how do you treat them? Symptomatic. What's symptomatic for viruses? Rest, fluids, antipyretics. Have I said that enough about viruses? Symptomatic. And we know mycoplasma is a more complicated pneumonia, and we do have that vaccine now, so pneumococcal is really pretty much gone away. Now, the aspirations pneumonia could be due to those powders. I mean, Johnson & Johnson baby powder smells so wonderful. And I used to love it on my babies years ago, before we knew about these aspiration risks. We can't use it anymore. in the air, can go into the lungs and create problems. The other aspiration is feeding, not burping them, not sitting them up, overfeeding. Feeding is one of those things that can cause aspiration. Now, foreign body aspiration. What do you think is the most common of things that kids swallow that get stuck? What do you think the most common is?
Coins,
What coin would you think?
quarters,
It is. It's the biggest one of all of the coins I've seen. I think I've seen one nickel. All of them are quarters, and I've seen, about 10 of them. I mean, kids, what do they do in the mouth? And they're all at that 3 to 4 age, and they put them in. Would you like to know how they remove a coin today? It's not bronchoscopy. They don't do that. What they do is they sit the child in the surgeon's lap and they put a Foley catheter down the throat and blow up the balloon because it's now below the quarter and tell the child to cough. They cough, they spit up a little bit, and the coin falls on the ground. Now, that would scare any small little child. So, again, nursing has to take control of the situation. I always tell that child, okay, he's going to pull that out when you cough. And whoever gets that quarter first can keep it. And I need that quarter. So you better hurry up. So now that child's not thinking about this going on. They're thinking about getting to the floor and getting that quarter. And that's what they do. And they forget to be scared. I've had many a parent, especially mothers, say, thank you for doing that because it eliminated that stress. So, again, that's a nursing care. Pertussis, we shouldn't get it, right? There's an immunization for it. Remember, pertussis is extremely contagious. Treatment is airflow room because it is so contagious. It's airborne, and we're going to be given Zithromax. That's all it needs in order to cure it. We shouldn't have it around, but there's many parents that don't believe in immunization. So again, if we see a cough, this whooping cough, and you can hear the whoop in it, believe it or not, we really need to put mask on, get the child in the airflow room, and protect you and everybody else. Smoke inhalation, we see this a lot more with fireplaces that don't work, or burning inside the house for some reason, or again, fires, of course. We treat it with 100% oxygen. Tobacco smoke. This is one of the things that causes ear infections in children and many other things. Again, we know that it affects unborn child, etc. So no smoking around children. Now, the next couple slides are on cystic fibrosis. You will have several questions on cystic fibrosis. So let's go into what it is. Cystic fibrosis is inherited disease. So again, both parents have it, 25%. This is what it goes, just like sickle cell disease, same sort of way that you can get it, okay? Now, it affects 3 different body organs. It affects the lungs. The lungs are full of mucus. And those mucuses are like big petri dishes waiting to get bacteria and grow it and be infected. That's the first organ. The second one is the skin. Electrolytes are sweated out like crazy, in particular sodium. You never restrict sodium on these children. They lose it like crazy. And then the third thing is the pancreas does not secrete this enzyme that the child needs to digest fat. So these children don't digest fat. So the fat goes in and goes out the other end. So what are you going to see? Salty skin. And if you were, and I'm not telling you to, but if you were to lick the skin on a child with cystic fibrosis, you would taste sodium. I mean, you would taste like it's salty, okay? Their lungs, we know there's going to be coughing, there's going to be mucus infections, et cetera, all sorts of breath sounds, wheezing, rhonchi, everything is going to be there. And then because we're not digesting fat, fat goes in and goes out, and it's greasy and foul smelling stools in there. And then The big thing with this problem with nutrition and not digesting fat is you're not getting enough calories. So it'll be poor growth and poor weight gain. Fat is the highest calorie contents of all foods. It's over double of protein and carbohydrates. So, how are we going to diagnose cystic fibrosis? Well, sometimes you know at birth. You've taken those tests when you were pregnant, but not everybody takes them for whatever reason. How would you know at birth if a child had cystic fibrosis? And you would know. This is a child
Genetic
that would not,
testing?
they would have no bowel movement in the first 2 days of life. This is one of three different things, and you need to know this. It's called a meconium ileus. No bowel movement in the first, they say up to 36. I say up to 2 days, no bowel movement. They will check for cystic fibrosis. And the test for it is a simple sweat test. They're looking for the sodium on the skin, and they just put these little stickers here and they measure sodium levels, and that diagnoses it. Okay. It's lifelong. There's no cure. This is something they have to live with. So, antibiotics, a lot of antibiotics, whether they're aerosols, oral, IV, because of multiple lung infections of them. There's going to be CPT, pulmonary care like crazy. Remember, dilators, your bronchodilators first, then chest CPT before meals. You don't want them to puke, okay? And then we're going to be given something to help these children digest the nutrient, the fat that they can't get because they need the calories. And we give a pancreatic enzyme. There's a specific way to give them. Number one, there are capsules, there's powder, there's little beads. Number one, capsules, you can open them. Those little beads, you can't crush them, but you can put them on a little food and take it because these must be taken with meals, immediately before, with meals. If they use the powder form of this pancreatase, it's just like some of those asthma medicine where you have to rinse your mouth out because it affects your enamel on your teeth. Same thing. And then the other thing about a medicine, like any medicine, is that you have to adjust the dosage as they grow. I mean, how many kids all of a sudden 1 year grow 10 pounds, gain 10 pounds, and the medications haven't been increased? So let's clear the airways, give the bronchodilators. Exercise is not an option. They must. And I will always tell you swimming is the best exercise. Think about the deep breath going underneath, what it does, beep into the lungs. It's great. Again, aggressive treatment of pulmonary infections. I'm talking aerosols with antibiotics in it, IV PICC lines, and they will be getting it. Diet enzymes, just like I told you to give, high protein, high calorie, low fat. Remember, it can affect cystic fibrosis, can affect mouth to anus. It can be reflux going on, and it could be a problem with an intestinal obstruction. So monitoring both of those closely. Cystic fibrosis, because it affects the pancreas, can turn into diabetes as they get older. Diabetes mellitus, again. So one of those things to monitor this child. Another thing, men. It's another obstruction of mucus. They cannot get women pregnant if they have cystic fibrosis. Women can get pregnant. I mean, as long as a man can make her pregnant, it will be a high risk pregnancy, but it's not a problem. Men, because of the vas deferens that's clogged and the sperm can't get to the woman, they can't. But if they opt to do a double lung transplant, 1 year post transplant, they can have a baby with their partner. Sleep apnea, just like me and you, if you're hearing the snoring, or a child who's sleepy during the day or getting, really their behavior problems, aggressive because they're tired, because they're not sleeping well, this is something we can look at, just like adults. We do a sleep study. Now, with children, we might do tonsils and adenoidectomies. It might be an airway obstruction issue, or they might need that BiPAP, just like adults, but a pediatric size. Again, it's figuring it out and getting it quick so they get the sleep that they do need. Now, the lungs, when they're injured, they sometimes are not showing how badly they're injured up to about 3 days later. It can be caused by sepsis, trauma, drug overdose, or near drowning. But let me explain it to you using near drowning. So you have a child who you found in the pool underneath, and they were out. You jumped in, got them out, brought them up, and somebody's calling 911 to get somebody there quick because, kid's underneath the water. You get the kid out, and however you do it, the kid, you spit out the water and they're breathing. And by the time 911 comes, they're running around and everything's good. And the parents going, oh, we don't need to go to the hospital, but thank you for coming. And the ambulance says, oh no, the child has to come. And you're concerned why. The thing with lungs, it can take up to 3 days later for the signs and symptoms to show. They must be admitted in a hospital with some sort of pulmonary monitoring, a step-down unit, an O2 saturation monitor, because they can shut their lungs down and go into respiratory distress, requiring even beyond just mechanical ventilation, could be going on ECMO. And ECMO is just to give oxygen back to that baby. I was ECMO certified at the hospital. All it does, it takes the blood out of the baby, puts it in a machine, gives it oxygen, and puts it back into the baby. It's not cardiac output, it's purely oxygen, and it gives the lungs a chance to rest and heal before we take this machine off and make them work by themselves. CPR was on your last exam. 15 to 2, 30 to 2, one man, 2-man CPR. There are differences, something you should look at. Remember, small children with stuff that they can put in their mouth. Remember, abdominal thrust and back blows. These are just little small things for airway obstruction. But what about the parents? What about the people that were in the room when a child codes and now you're performing CPR, code blue going on? Remember, have somebody with those people, whether not necessarily you, it could be a care rep, it could be social worker, supervisor, anybody, another person from your unit. Again, it's a lot to go through. Now, asthma. This is the most common reason for absenteeism in school because of asthma. Asthma is a hyper-responsiveness to antigens, allergens, something they don't like. It could be cats, dogs, it could be mold, it could be grass, it could be anything that can cause the lungs to say, oh, I don't like it, and they inflame, and now air can't get out. That's what happens in asthma. All of a sudden, the coughing, and you cannot, and it's like, you're trying to breathe, and it's an absence of breath sounds almost. My husband has asthma, and when he goes into these asthma attacks, when I'm trying to listen, and I have a stethoscope, of course, listen to his lungs, when he tries to get the air out, I hear did you hear the sound of that squeak? That's it. That would be air coming out, not like you should hear. You don't hear air going in, you hear on the way out. And that asthma can turn into status asthmaticus, which is what we don't want. So how do we manage asthma? Well, PFTs, let's look at the lungs, let's see how they're functioning. Let's find out what the allergens are. Let's prevent them from being around you, or sometimes you get desensitized for them. We want kids to be normal, act normal, be a kid, okay? But we've got to give them that ability to not have asthma attacks as they're doing it. Drug therapy for asthma is just like adults. There's no change. Same thing. We're going to be using albuterol, Vental, and whatever you want to call the name, rescue when we need to breathe. we're going to be taking those preventative of bronchospasms morning and night. In children, that's called Pulmicort. Just like adult stuff, Advair, Brio, Symbicort, again, preventative. They're going to take that Singulair at night after the age of 2, and it does help. As I call it, it is the allergy pill for asthma. It's like a Claritin for asthma, but it's called Singulair. And status asthmaticus. Now, my husband, unfortunately, a couple of years passed. He was in the ICU when it happened. Well, he was in a hospital, moved to ICU. He had status asthmaticus. And the thing about any respiratory problem, now, if I wasn't there, he would have been intubated, probably had a tracheostomy, but I could talk him down. My point here is when you have any child in respiratory distress, number one, have them sitting straight up, right? High Fowlers. Number two, get them calm, whether that's sitting on mommy's lap, whether that is whatever, get them calm. If you keep them calm, it's going to prevent that spasm from going further. There's all sorts of pharmacological theophylline and whatnot, but what I'm saying is a lot of it has to do with positioning and just calming the child. Who wants to win a respiratory Kahoot today? I think Miranda's on the way today, and Lauren, and Jennifer, and Alessa. Where do we go? You know, one of the things about respiratory, I don't believe I've mentioned it here, infants are very strange. Infants, when they're respiratory distress, they are very particular what they do. Infants, their noses will flare. You don't see this a lot in older children. Another thing they do is after every breath, they grunt. It's like their nasal flaring, and you hear this after every breath. And if you are in a room and you have an infant that is breathing like that, you need to get the crash cart in there quick because they are that close to arresting on you. It's that little, and you see the head. You can see how a kid would be bobbing and the abdominal breathing. Erica, come on camera, please. Marjorie, I think you tried to clean your camera and you've turned it a camera off. You go up top where the camera is. If you click it to the left, there's a little switch in there by the little camera on your computer. You'll turn your camera back on. Shauna, you're off camera too, please. Avery, please, come on camera. Let's get going.
Right, I just walked back in, but I put in the chat I went to the bathroom. I didn't do it on accident.
Okay, I just want you to know that your camera, the way that you did it, looked like it was off. I was trying to help you. It's okay. A majority of upper respiratory infections are caused by upper respiratory. What causes them? Now, Marjorie, a couple terms ago, I had that little camera looking thing and I didn't know what to do with it. And I found out it's because I cleaned my camera on my computer, what it was. All upper respiratory infections, 95% actually, at least that much, are viruses. Very rarely are they bacterial. You walk into a 6-year-old's room and you find them not breathing and doesn't wake up. What are you going to do? So you walk into a room and you find a person, adult, child, doesn't matter. They're not breathing. They don't have a heart rate. You always start compressions first. Years ago, you gave 2 breaths and then did compressions. Do you know why they changed that? is because if you're out in the field and you saw a person laying on the ground and you needed to start CPR, many people wouldn't because you should give a breath and they don't want to put their mouth on another person if they don't have that little thing to use. So they said and did research that the body has enough oxygen in it for quite a while just to do compressions. It will just get the oxygen around the body. That's why we don't do breaths anymore.
Would you
First,
not only do compressions if their heart wasn't beating though?
they wouldn't be breathing. How would you administer cool mist to a frightened child? Think about it. If the heart's not beating, are they breathing? They're basically dead. Cool mist. This would be that child with bronchitis, croup. And we need to moisten that airway. Again, put them in the parent's lap, have the parent wave it around. That's what you want to happen. You don't want to do anything. Could you imagine putting a mask on the face and securing it, and that kid just feels like they're suffocating? So anything like that, I wouldn't do. You don't want to take a respiratory child and make them more upset. Multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? You could take this and say, if a child isn't feeling well, what are some signs and symptoms that you would see? If they have a fever, they don't feel well, they're going to be sitting in the corner, they're not going to eat. If they're not eating, they might vomit and their tummy might hurt. So, how are you going to treat this? Treat the fever and everything else will work, right? A multi. What do you look for when assessing respiratory function? It's like, how do you assess your lungs? Breathing. So we look about everything, the rate, if they're labored, the ease, how deep, how fast, all of that stuff is what we want to look at. And then, of course, then we'll listen and find out what we hear. What would you look for after a child has a tonsillectomy? What's your biggest concerns? Just got the kid out of the OR. Status post tonsillectomy. So once the child comes out of the OR, usually they don't have pain yet. It's what they do today is they numb the area so much you don't feel it that much till the next day. What our biggest concern with tonsillectomies is bleeding. I'll tell you why. When they have tonsils there, they take scalpels and basically cut them off, all right? And then there's little capillaries and bleeders. So they cauterize them. So what's left is two big scabs on either side of the throat. So the chances of the scab to move is great. And the bleeding will occur then. So if you're swallowing, there's something there to swallow. It's the blood. That's what they're concerned about. This is why immediately post-op, if they're still really groggy, we're going to have them side lying. A multi. Nursing care for a child status post tonsillectomy include so right after they come out of the OR, our biggest concern is pain, right? So again, pain medicine. And today all we give is acetaminophen. I mean, years ago we gave hydrocodone, but we found children were overdosed and they really didn't need that much medicine. They're not used to medicine, so acetaminophen worked. Gum is given to older kids to pop their ears because of the pain and pressure. Those gestation tubes are right there where they did surgery. And then the ice bag, this is older kids. If you put it there, it helps with the pain. A multi. What signs and symptoms would you see in a child with otitis media? So the thing with ears is they don't always have fevers, okay? That's a misnomer. In fact, many times not. What you're going to see is ear pain. Sometimes that ear has already burst, and you might see some exudate, purulent ear drainage. It's yellow, golden. It's really purulent. And then, of course, kids are sick. They lose their appetite. That's just part of the whole thing, okay? What is your priority care for a kid with otitis media? Pain. Treat the pain because antibiotics take too long. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? So the two names, tracheobronchitis, bronchitis is the same thing. No, bronchial tracheobronchitis, know the different ones here, okay? The monthly immunization for RSV. Remember RSV, we're more concerned about the little babies, less than a year. And this is when we give it, and it is monthly. It's gone from winter to early spring. And it is called Synagist. Hib is that Haemophilus influenza vaccine we give it to for 6 months. Indocin, we're going to get that into the cardiac land, and we'll do that next. I'll let you know. A 4-year-old child's been taking meds for asthma, and the child is still wheezing. So, what information is important? Why is the kid still wheezing? Is it he just that sick, or is there a problem? So if you have a child who is on, medicines, usually it's the MDI. Remember, a 4-year-old, can they really take it properly? Have them do a demonstration for you. And usually that's what it is. The spacer is a great thing. It's a little mask with a little tube. You put the little MDI in the end and you squirt it whatever the dose is. They inhale a couple times. And even if they're crying when they inhale, they're getting the medicine. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Sort of need to know vital signs that are normal for an 8-month-old here. Respiratory distress, 8-month-old. And it's just that signs, which is substernal retractions and restlessness. Respiratory rate of 25 and 108 is a 8-month-old who's sound asleep and fine. O2 sats of 95 on a child is fine. Under 92, we treat. And then having an 8-month-old abdominal breathing pulse of 100, that's normal. Signs and symptoms of asthma include all except remember, asthma is all about air getting trapped and we can't get it out. We get air in, but we can't get it out. Remember, if you have a bronchospasm, the first thing you're going to do is cough. And of course, it's expiratory wheezing and short of breath. Yes, and you're tachypnic and tachycardic, but a prolonged expiratory phase. You can't get the air out. It's trapped in asthma. What positioning helps oxygenation during asthma exaspiration? So again, when you are in any respiratory distress problem, the positioning is always your number one you want to do. Having them sit up, high supported, get their arms up so they're being able to breathe, that diaphragm drop, and get the best that they can to breathe. What should you not do to children diagnosed with croup and epiglottitis? And I could put in there tonsils too. Leave the mouth alone. When you're talking about an inflammation, an itis, swelling somewhere, you don't want to make more. So leave it alone. Only a person who can intubate can go and look in the mouth with like a tongue depressor, etc. Nursing interventions with a patient with epiglottitis would include got a kid with all the symptoms, shortness of breath, tripod breathing, drooling, garbled speech. Putting him in a room, what are you going to do? Airway, 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 isn't it? Intubation tray at bedside. If you are worried about having suctioning with epiglottitis at the bedside, you're putting nothing in that mouth, you're not suctioning. And you're not going to give a person who can't breathe anything by mouth. Warm, cold, don't matter, okay? Which triad suggests epiglottitis? And that's again, it starts with that sore throat, swallowing, drooling. A multi. Treatment for infectious mononucleosis. So remember, mononucleosis is an Epstein-Barr virus. No antibiotics are required. Remember, with a virus, what do we do? Symptomatic treatment. Rest, fluids, antipyretics. And the big thing with mono is please take care of that belly. You might have a swollen lymph gland, the spleen, or the liver, and with abdominal pressure, it could burst. And like my little boy, you could die. Multi. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? So you're admitting a child, doing an admission history. What do you need to know? So when you're admitting an infant, okay, they have a fever and a loose cough. Number one, I want to know their immunization status. Is this pertussis? Is this RSV? What is it? I need to protect myself and all my other patients around me. The things that I need to know for nursing care, I need to know what is the fevers, how high they've gone. Also, when did you give the last doses of medicine so I can continue? You don't really need the APGARs at birth because we're just dealing with right now what is the problem at the current time. How is cystic fibrosis identified? Remember with cystic fibrosis, if we don't know because we've done that screening before, remember meconium ileus. When we see no stool at birth for the first 36 hours, I say 2 days. If you don't see a stool, think meconium ileus, think cystic fibrosis, and we're going to do a sweat test. Looking for sodium, a lot of it. A male wants to be able to have children who has cystic fibrosis. How is it possible? Remember, those vas deferens are clogged up with mucus. So you have a male who has cystic fibrosis. What we can do is a bilateral lung transplant. And it takes about a year afterward. And then they say that they can father a child. It's a big commitment for a male to be able to have a baby, to do a double bilateral lung transplant. It's big, big surgery. A multi. What is included in the plan of care for a child with cystic fibrosis? Remember, it's three things that go on. We've got the sweat, we've got the lungs, and we've got the pancreas. All big problems. So how are we going to deal with it? So why would you like to give a low sodium diet to a child who is losing sodium out of their sweat like crazy? I mean, if you licked it, it'd be so salty. I mean, it's profoundly salty. This is a child that you're going to give a salt shaker to, but it's going to be, giving a lot of chest CPT, giving the enzymes with meals, high protein, high carbohydrate, low fat diet. What medication would you hold for an infant that is vomiting and the vital signs are 98, 88, 32? So, digoxin. Now, I put a couple questions in this Kahoot to show you how sometimes you need to know some vital signs. All right. With digoxin, one of the things that students like to say, I see yellow spots because it's part of the adult part of digitoxicity. Remember, an infant can't tell you that. What can an infant tell you? Nothing. But they can show you a low heart rate and they could show you that they're vomiting. An infant on dig that is vomiting, you're going to hold the dig, call the doctor, and get a digoxin level. Safe is better than sorry. Which information is most important when rheumatic fever is suspected? Now, rheumatic fever is something that's caused by strep, okay? So it's sort of a sore throat sort of thing, but it involves not only respiratory, it does involve cardiac too. So I put it here. So you can see it actually twice. I'm going to tell you again. But rheumatic fever is due to strep that was not treated or undertreated. Symptoms, big symptoms that they show. They're going to have that sore throat, that fatigue thing. They're also going to show polyarthritic nodules, rash. Another thing, chorea, which is that weird central nervous system movements. You can't control your movements. And then the one thing they cannot cure once we start long-term antibiotics, which will take care of everything else, is any sort of heart valve damage. This is usually mitral valve is usually damaged. And if it gets damaged, antibiotics won't help. It's only medically or surgically taken care of at that point. Signs of shock in children include all of the following except so what is shock in children? It's the same thing as adults, isn't it? Same sort of symptoms. You're going to have that altered mental status because you're not getting perfused in your brain. You're going to have hypotension, tachycardia, poor capillary refill, decreased urine output. All of these things are going to show shock. Which of the following is the most common cause of shock in infants and children? Most common. And it's infection. Remember, infants and small children do not have an immune system yet. So if they get an infection and we don't catch it quick enough, it will send them into shock. First signs and symptoms of children, infants, premature, you will see periods of apnea and bradycardia. That's showing you that something's going on. And that's where they start working them up for infections. Apnea, bradycardia, that's all we need to see. Multi. Signs and symptoms of rheumatic fever include remember, due to a strep infection. So you get a kid coming in that's showing all these weird stuff and you don't know, and the chorea and the sore throat and respiratory distress and these nodules and polyarthritis and all of that. You could say, have you had a sore throat recently? And remember, we can go with a blood test and check ASO titer, anti-streptolysin titer. Strep is in there. It's telling you if there's strep in the blood. That would be the definitive test. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What's the nurse's priority? I mean, they had surgery. They need to cough. They need to expectorate. What's your priority? How are you going to make them do that? So again, if you had a child who had abdominal surgery and can't cough, and they can't get secretions out, we know there's going to be post-op complications. So number one, let's medicate them for pain, okay? After they're medicated, they're going to do all the above. Move them, turn them, position them, out of bed, ambulate, incentive spirometry, et cetera, et cetera, et cetera. Number one, remember, pain medicine will let them do what you need them to do. How would you position a child's status post tonsillectomy? And we want them side lying. Why do we want them side lying? Because they're on their side. If they need to bleed, it can come out the side, and we still maintain the airway. Prone on their tummies, we can't monitor any airway that way. An infant of 3 months has a fever of 103.6. What are you going to medicate this infant with? And why do we medicate fevers? It's just because of the discomfort. And kids who have a fever don't eat or drink or nothing. Medicate them for fever. Fever comes down. They're eating and drinking and playing and happy. Infants under the age of 6 months can have nothing but acetaminophen. After 6 months, and at 6 months, we can introduce ibuprofen. There's something with the NSAID and platelet aggravation, sort of something with bleeding, something they do not tolerate it till they're 6 months old. A multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? You're going to say critically ill children, they're not sick that long. I have seen in 6, 8 months in a hospital, critically ill in the ICUs, and they do get all the things that adults get: foot drop, decubitus, pulmonary DVTs, everything. They do. So we have to do everything to prevent it instead of spirometry, keeping them dry, using chucks, using diapers, turning every 2 hours, using pillows, blankets. How about using stuffy animals? They can take their big teddy bear and hug it. I mean, these are things that we do for children. How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? We use oxygen on infants quite a bit because At birth, many infants have a little bit of mucus from mommy left in their lungs, and they have TTN, transient tachypnea of the newborn. They're absolutely normal, perfect infants. They just need a little time, a little oxygen until they're able to be without. Now, this clear plastic hood, they can have their fingers in their mouth, they can look at the life, and they can suck on a pacifier, and it is actually very, very accurate. A nasal cannula has prongs that tickle their nose, and you have to tape it on their face to keep it there. It is very bothersome. It's not tolerated well. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? So when you're talking about keeping lungs open, this is all about good pulmonary toileting, which is deep breathing, coughing, using your albuterol to expand lungs, using CPT, ambulating PRN. No, there's no question. It's TID, BID, QID. It's not up for debate. They have to get up and move. And of course, exercise. And I will always promote swimming. Again, deep breath underwater gives good pressure in the lungs. And last question, a multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? They need to know how to take them to do it right. So with pancreatic enzymes, you need to take it right before or with meals on that first bite with a little bit on the food, okay? Those little capsules, you can open it and put it in food if they can't swallow it. But the little beads, don't crush them. Leave them alone. Any enteric type stuff, you can't do that too. Another thing, if they use the powder and put that on their food, make sure you rinse their mouth, just like some of those respiratory medicines. It messes with the enamel on their teeth. And also, again, as they're growing, make sure we increase the doses. I think that's probably the one thing we fail at a lot. Okay. Number 3, Miranda. Good job, Miranda. Number 2, we got an A. And number 1 is, drum roll, ding, ding, an H. We got a good H. What else we got? We have a Lauren and a Jennifer. All right, let's go on into cardiac. Cardiac is a little bit more. So let's go back to our PowerPoint and continue. All right, let's talk about cardiac now. Now, just to get yourselves a little bit more at ease, the questions on the exam are more respiratory than cardiac, but there's some key concepts within respiratory. I sent you a handout. It's a respiratory cardiac handout. It is a great guide to show you the things, the names, the procedures you need to know, the meds. It is a great handout. So use it, okay? So, types of cardiac defects. Well, you're either born with it or it's something happens and you acquire it along the way. If you acquire along the way, it could be an infection. You know, many times I see they're viral infections, viral cardiomyopathy, not uncommon. I've seen it quite a bit. How about that autoimmune lupus attacks that sort of your heart or any other big organs, right? If your family is sort of attuned to it, could, and of course, environment. Now, here's a picture from your book, and I want to explain, number 1, how a drop of blood goes through the heart and where the valves are, Okay, very important. If you don't know it, write this down because is it right-sided or is it left-sided? And these are some things that you're going to have to understand a little bit about. So let's trace the blood as it comes back into the heart. It comes from the vena cavas into the right atrium. It's no pressure. It hardly gets back to the heart after going through the whole body. So pressure's low on the right side. It goes through the tricuspid valve into the right ventricle, up through the pulmonic valve into the lungs. Now we've done all of that oxygenating and get rid of carbon dioxide, and now it comes back into through the pulmonary veins into the left atrium. The one thing I didn't know, there's actually 4 pulmonary veins. I didn't know that till a long time ago. Anyway, it goes through the left atrium, through the mitral valve, and that's the one that's usually damaged in rheumatic fever, down to the right ventricle, through the aorta, and to the body. Now, think of this blood flow as a garden hose. What would happen if after the blood leaves the left ventricle through the aortic valve, up through the aortic arch, all of a sudden it kinks and there's a narrowing, a stenosis in that big tube that's coming out to feed the body? What would happen? Well, what would happen if you had a garden hose and you kinked it? Blood or water can't get down out of the spout, so it has to go backwards. So think of backwards sort of where this blood goes. So there's a condition called coarctation of the aorta. It's a kink in the aorta. That means it's a kink. No blood or minimal blood is going down to the feet. What are you going to see with minimal blood flow going down to the feet? Well, decreased or no pulses on the feet. Dorsalis pedis, posterior tibial, you're not going to feel anything. Now, if I see this, no pulses in the feet, what am I going to do? Because I now have a suspicion there's a kink, blood's not going. I'm going to do a 4-extremity blood pressure. Now, what am I going to see? How am I going to make this diagnosis of coarctation of the aorta? Well, if blood can't get down to the feet because there's a kink, the lower extremity blood pressures are low. There's no blood flow. And because it has to go backwards, it's going into the upper extremities. My upper extremities are going to have a higher blood pressure. What's going to happen to that blood that can't go down to the feet? It goes back into the left ventricle, goes into left atrium, and it fills the lung up, and now you're in heart failure. That's coarctation of the aorta. And it sort of describes many sort of congenital heart defects and the symptoms you might see. So what do you see with a congenital heart? They don't have enough oxygen, okay? Something's going on. The blood flow ain't doing what it needs to do. So I'm not getting the oxygen I need to live and survive. So I'm not going to eat well. I don't have oxygen. I'm going to be tachypneic and tachycardic because I'm trying to get that oxygen around, but there's no oxygen, but I keep trying. Because I keep trying so hard, I'm burning up my calories. It is failure to thrive, poor weight gain. I'm not going to be able to drink, so I'm not going to gain weight. I'm not getting my nutrition, so I'm not filling the nutrition tank. So no gasoline in the tank, nutritionally, cognitively, I'm going to be delayed, okay? It could be part of what a family is. It could be, we know something has been going on with that child. Now, in heart failure, when it suddenly happens, you see weight gain. As it continues over time, you're going to see weight not gaining and loss because of the burning. Okay, there's a difference. So, what are we going to do for these children? Well, we're going to weigh them every day. We're going to make sure that they're not gaining weight, extra fluid, that they are losing weight. What are you going to see in a child with cyanotic heart disease? Well, we're going to be looking at many things. Well, nutritionally, we're going to know if they're not gaining weight, something's going on there. Color, look at the chest. Clubbing of fingers do not happen till later on, okay? We're going to look at the way the heart is beating. Is it fast? Is it slow? We're going to look at peripheral pulses. And then we're going to listen. When you have a murmur in the heart, especially a ventricular septal murmur, this is a hole between the bottom chambers. The sounds on a heart usually goes cha-chung, cha-chung, cha-chung. When there is that big ventricular septal defect or a VSD, it's a loud murmur and it sounds pow, pow, pow. You actually can feel the vibrations on your hands on the chest. So you get this kid in, we know something's going on, we believe it's cardiac, so we do an EKG and we do an echo. In the echo, we see things going on, so immediately they schedule a cardiac catheterization. It could be done to diagnose, or it could be done to take care of things. We use them a lot for a lot of transient tachycardia in children, but older ones, and those are on the electrophysiology studies. But you just need to know they need to go for cardiac cath for the diagnosis to figure out what's going on. Now, nursing care during cardiac catheterization. Well, let me explain first what they do. This is a procedure where under fluoroscopy, they insert two big catheters in the right femoral vein and right femoral artery. And they insert dyes and shoot it, and they look at the way it goes through the heart to figure out what's going on. When they're done, they pull out these two big catheters, hold pressure on it till the bleeding stops, put on a pressure bandage, and sometimes older kids a sandbag to hold it so it doesn't bleed. So once that's done, the kid's recovered, the child goes back to the unit, and you're the nurse accepting that child from cardiac cath. The first thing you need to check is that dressing. Can you imagine a 8-pound baby having that femoral artery, the clot come off and bleeding? They could bleed a lot real quick. So number one, check the dressing. Keep that right leg straight because you don't want to take the clot and bust it off and cause that bleeding. You're going to document vital signs, pulses, what that extremity looks like, and younger kids you do a glucose on because sometimes they didn't get sugar in IVs and they don't tolerate hypoglycemia. What is the biggest risk for cardiac cath? Hemorrhage. Hemorrhage postoperatively. They don't have cardiac dysrhythmias, they don't get infections, none of that. It is hemorrhage is the big problem. So congenital heart disease, most common is a VSD. And the child, which is the most common, that gets cardiac problems is your poor little Downs child, whether they're 13, 18, 21, whatever their number is. Poor Downs child, this is another thing we have to be concerned and monitor for. So there's two sorts of heart disease, acyanotic and cyanotic, okay? So let's look at what are those differences. So acyanotic means their O2 saturations are pretty well normal. And that's with children, which says above 92%, and that's okay with them. Now, let's look at this increased pulmonary blood flow. Like, when would that happen? I don't understand. How does that go on? Well, let's look at the heart at birth. In between the two atrium at birth, there's that something called that patent foraminal valley, which is a hole, right? It's at birth. And we know every child has it. It's part of fetal circulation. And sometimes the most common of all defects is a ventricular septal defect, a hole between the bottom chambers. What happens? Well, blood comes in through the left side back into the heart. Big blood flow going on. And it goes from the left side over to the right side because that's where the blood flow. Right side has no pressure. That's like the end of the line of blood coming in. So what happens? You take oxygenated blood just back from the lungs, and it goes back into the right side of the heart and goes back into the lungs. And that's why they say increased pulmonary blood flow. Do you understand that? There's a hole. It goes from high pressure to low pressure. So from the left side to the right side, and it goes back in through the lungs. Now I want you to look at the name patent ductus arteriosus. This is another name for that fetal circulation. This is a oxygen giver, and I want you to think about it this way. PDA, oxygen giver. It connects the lungs through the pulmonic artery, and it connects it to the body, to the aorta. So this is an oxygen giver when all the kinks and holes and there's no blood flow and you can't get oxygen anywhere. And I'm going to give you a second where we need this. There's no flow going anywhere. The obstruction to the blood flow, I've already talked about coarctation, and I want you to know the word stenosis. It means a narrowing. Atresia, A is without, there's nothing. The next one goes to tricuspid atresia. That means the valve between the right atrium and right ventricle, there is none. Okay? Now, decreased pulmonary blood flow, tetralogy of Fallot, cyanotic heart disease, the most common congenital cardiac heart disease is tetralogy of Fallot. And they love to cover this on their NCLEX. They love to cover tetralogy on your HESI. So let's explain it just a little more. Tetralogy is a right side of the heart problem. Blood at times when the pulmonary artery closes up doesn't let blood go to the lungs. So you don't get oxygenated. So you go from O2 sats of 100 to 10 quick. It like spasms, it closes it up. So what do you see? So tetralogy of Fallot, you're going to have pulmonary artery obstruction because blood can't get up there. Sometimes that right ventricle gets stretched out a little bit. Many times the heart tries to protect itself, and the body does, and the baby is born with a hole between the bottom chambers. So they have a VSD. And then the aorta sort of pushes over, but that's tetralogy. Now, I want to tell you about a little boy called Nolan Ryan. He had a TET spell on me one night at 5 a.m. in the morning. And he went from O2 sats of 100 to 10, less than a minute. He was a pink baby, and he turned gray, purple, blue instantly. So what is the treatment for TET spell? TET spell, hypercyanotic spell, tetralogy, a Fallot, TET spell. Well, that pulmonary artery got a kink, something covered it, not letting blood flow. I've got to do something now to get oxygen to the baby. And you take the knees and you push it to the chest quickly. It's called a knee chest movement. Whether they're on their side and you quick push them, or they're on their back, you take the knees and you push them to the chest. I did it and it worked. And the kid went pink again, thank goodness. But this is called knee chest. Older kids that aren't repaired, it's amazing that if they're having a TET spell, they know to squat. That they'll be walking along standing, and then all of a sudden, poof, they're on their knees squatting, and they actually take care of their TET spell themselves. Now, you were wondering when we need an oxygen giver to the baby, where we have no oxygen. Think about this mixed blood flow, cyanotic heart disease called transposition of the great arteries. The aorta and the pulmonary artery are switched. There is no connection. There's no oxygen going to the body. The lungs go here and the body systemic circulation goes here. There's nothing going to the baby, no oxygen. How do we get oxygen to the baby? Oxygen giver, it connects the aorta to the pulmonary artery and it keeps going. Now, how do we do that? Now, during pregnancy, mommy secretes prostaglandins, and this keeps fetal circulation open, the PDA, okay? How do you know the PDA is still there? I mean, that's important if you have a transposition of the great artery, right? I know it's there because there is a loud washer machine murmur. I mean, you can hear it. Usually a heart, cha-chung, 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 but it's really loud and it swishes, and you know it's there. The other way we know many of these children, we put arterial lines in, an umbilical artery catheter, okay? Monitoring blood pressures. The diastolic is going to be very low. At birth, what is the normal blood pressure of a neonate? 60/40. A child with a PDA that's open, 60/18, around there. I mean, wide pulse pressure. That's why we would know that we had a PDA still open. So we have that transposition of the great arteries. Who needs an oxygen giver? And mommy's gone, not secreting prostaglandins anymore. And within 21 days, and usually a lot quicker, that PDA closes up, that baby gets no oxygen, and that baby's going to die. So how am I going to keep that oxygen giver open? Well, we have synthetic prostaglandins, and we give a slow, continuous infusion. And again, it maintains cardiac output and oxygen saturation levels. Again, it's an oxygen giver. Now, I have seen usually when you have these small premature infants, many of them have a PDA that never closed by themselves for whatever reason. I don't know why, it just doesn't happen. But we can either medically or surgically, we can close it. If we have to do it medically, we give a medicine called indomethacin. Indocin. It's actually an NSAID, and it's 3 doses. Now, I used to love giving indomethacin to my children because I used to like to listen to the murmur disappear. I used to like to watch the blood pressure come back to normal, and you know it was working. There's a bunch of different blood flow things. You can look at them the way they go, but I've given you what you need. So congestive heart failure. We sort of touched on heart failure. We know heart failure is when the heart's not doing what it needs to do and fluid is collecting wherever. You're going to see a weight gain, right? Take a blood chest x-ray. You're going to be full of fluids. So what is our goal with congestive heart failure? Well, we want the heart to beat better. We want them to breathe better. We want the fluid to be gone. And we want them, to have a better oxygenation. So what are we going to do? We're going to give some medicines for the heart, maybe digoxin. We're going to get the fluids gone, maybe with a diuretic, furosemide, very, very common. We're going to be doing daily weights, making sure, are we losing that fluid that we're gaining, making sure that we're working in the right way. Another thing with the treatment of congestive heart failure in infants, just breathing is a hard thing. Okay, their heart's not working well, they're full of fluid, so they need to eat. So suck, swallow, breathe, they're eating. And this is something that we have to monitor really, really closely on these children. Now, we want to make it as easy as possible. So if we only allow 30 minutes for a feed, you don't want to overtire them. You do your cluster care. You want to give them long periods of rest. Also, increase the calories in their formula. So you can take a 20-calorie formula and make it 30 calories. So you're drinking less fluid. So you're getting more nutrition in less volume and less time, which is helping that child relax and rest. Now, digoxin, very, very common drug. How do we give it? It's just like adults. There's no difference. You just have to know what's a different heart rate for this child. Digoxin levels are the same. Potassium levels are the same. We do the same thing looking at it. We know, what does DIG do? It slows and strengthens the force of contraction and it allows the heart better output than what it was, right? In infants, you may only see the vomiting. That might be the only thing that we see for DIG toxicity. So again, before you give it, apical pulse, 1 full minute, know what normals are or what the doctor says, hold for this number. Check the potassium, it must be normal. And again, if there's a recent digoxin level. If they're vomiting, I'm still going to hold it, call a doctor, and repeat a DIG level. I want to be safe. Hypoxemia can go and cause clubbing. What's another thing that can happen with hypoxemia? You know, many of these children are hypoplastic left heart children. I'm telling you, at birth, before their second stage surgery, which is about 8 months old, these children O2 sats are 65 to 75. Normal, it's where we want them. But what does the body do when they see low O2 saturations? It says, let me try to help out here. How can you help oxygen levels? Well, red blood cells carry oxygen, right? I don't have more oxygen, but the body says, let me produce more red blood cells. This is why many cardiac children are extremely polycythemic. A normal hemoglobin is 14. These kids can be 18 normal hemoglobin, absolutely normal for a cyanotic heart. So children and their parents and caregivers, every time I touch a kid, I'd be teaching them, educate, because they're very complex. Again, they're going to be taking care of the home. They need to know how to take care of them. Endocarditis. Again, this is just that prophylactic treatment for dental treatments, whatever. And then let's go a little bit more in depth into rheumatic fever. Again, rheumatic fever is due to a strep pharyngitis that was not treated or not treated completely. And what happens is they start with these symptoms, okay? They're still going to be remaining with a sore throat and all those things that go with it, but their joints, rashing, they're going to have that chorea, that weird movements that go on. And if we allow it to continue, it could cause permanent heart valve damage. Usually it's the mitral valve. Treatment, long-term antibiotics. And that's to treat the strep. And everything can be reversed except the heart valve. Once it's damaged, it's damaged. They can have high blood pressure. They can have high cholesterols, and we're monitoring closely now. Children can have all sorts of dysrhythmias. Do you think little infants can get pacemakers if they have bradycardia? I've seen one at 18 months old. It's about this big, but it was placed in the abdomen, not up on the chest where the normal adults usually they put them. And then pulmonary hypertension. What is it? Well, there are times where the lungs have been damaged and they go into protective mode, I call it, where they tighten up, spasm up, and they don't allow oxygen and carbon dioxide to be exchanged easily. So symptoms, these are children or adults. When you're working with them, they tire easy. They have absolutely no oxygen reserve at all. So they'll be dyspneic on any sort of exertion. With that is the chest pain and dizziness, again, hypoxia. Cardiomyopathy. Again, this happens when the heart gets big and floppy. Sometimes it's infection. I told you many of the times it is viral. Okay, it could be from lupus, could be any sort of thing that could have caused problems attacking that heart muscle. You know, we will go and we will treat, and we do these tune-ups all the time, but it gets to the point where they're not working, and then they need a transplant. The biggest concern of transplant, rejection, not infection. Many of you will choose it. No, no, no. I reject that heart. I don't like it. And that's the biggest. Postoperatively, many cardiac children, in fact, anybody with open heart surgery post-op will have a chest tube. Might be one, it might be five, depending on type of surgery, the size of the child, et cetera, et cetera. Now, part of my career, I worked as open heart for adults on the night shift. And every morning at 6 a.m., the residents would come in and pull out all the chest tubes. What I'm mentioning this for is I know how adults feel when their chest tubes are removed and what they tell me. When it's removed, there's this intense burning. It lasts for a little bit of time, but it is intense. So, knowing that, how are you going to teach a child that you need to take out a chest tube? Number one, be honest, let them know it's going to hurt, but you'll do everything you can to help them be as little as possible. And it's only for a little while, it's not going to last a long time. And you'll hold their hand. Another thing, you're going to take their vital signs for baseline, medicate them. That's why you take vital signs, and then explain it on their level. And then when you're done, you take vitals again because you've given medicine. As I said, hypertension, kids do get it, and we do treat it now. It's prevented a lot of kidney problems, renal problems, because we treat it quicker. Now, Kawasaki disease. Kawasaki disease is interesting. It is an acute systemic vascularitis, and we don't know why. We don't treat it with antibiotics. We treat it by boosting their immune system. I've seen several cases, and what's interesting, they come in, their eyes are big and red, like glow in the dark. They also have their lips are cracked, big red strawberry tongue. They can have a rash. They can have lymph nodes are big. One of the things I've always checked for is their palms and their soles of their feet. They could be peeling or they could have blistering on it. Okay. Now, what is our big concern here? This is just a problem with systemic vascularitis, right? Well, they're worried about the coronary arteries. They could have an aneurysm and burst, and that would be the end of the child. So, treatment, we've got this itis going on, this vascular itis. So, we want the body to try to help itself. So, we're going to give intravenous gamma globulins, IVIG. And then we're giving high dose aspirin. Why do you think we're giving aspirin to a child with vascularitis? Why? Anybody?
To increase blood flow.
Okay, because it thins the blood and it will stop clots from being formed. And then again, you're taking care of that child, getting the blood flowing, you're decreasing the chance of this coronary artery aneurysm and the IVIG in order to boost the system. COVID, we've all lived through it, right? And look at that, treatment is similar to Kawasaki. Shock, we know the most common in children is that septic shock. Anaphylaxis. Children have not had medicines, foods, anything. Chances for anaphylaxis are great. I always say, always be prepared. Anytime you give medicines to a child or something new, always be prepared. It can go into an anaphylaxis. Septic shock. Usually, what do we see? Early stages of shock, you're going to start seeing little periods of apnea and bradycardia, which get more and more and more prolonged. Toxic shock. This is the tampons in your adolescents, just to let them know. And now, let's see who can answer this one. Surgical closure of a patent ductus arteriosus would result in which of the following? What's a PDA? It's an oxygen giver. It takes blood from the lungs, pulmonary artery, and it gives it to the aorta so that we give oxygen to the body. So if we close it off, what happens? It prevents return of oxygenated blood to the lungs. How's that sound? All right, who wants to win this part? Have I lost you yet? Almost? Okay, I quick ran to the ladies' room. Thank you. Now we're into the heart. This is a smaller cahoots. It's a littler portion on your exam. Why would a child with tetralogy of Fallot not gain weight at the normal way? Remember, tetralogy of Fallot is a congenital cyanotic heart disease. So remember, with tetralogy, if we're not getting oxygen, you don't have that energy, you're not going to have the desire, and you're not going to eat. So, of course, you're not going to gain weight. A clinical manifestation of Kawasaki disease. Chorea is rheumatic fever. I want you to remember that now so you don't forget that when you come to your exams, okay? Chorea is rheumatic fever. Kawasaki disease is that hands with the blistered palms and soles, the strawberry tongue, the reddened eyes, and the rash. Which of the following best describes the pathophysiology of Kawasaki disease? So Kawasaki disease, we don't know what it's caused from. It's not treated. It's not bacterial. It's a multi-system vascularitis, and our biggest concern is that coronary arteries and having aneurysms. What is the treatment for Kawasaki disease? So this is the one time you'll ever hear me say, give a child an aspirin. I know some of the progressive new stuff in older children would be Coumadin, but I've only seen aspirin and IVIG given. Remember, it is not a bacterial infection. It's not antibiotics. A multi. Why do you give aspirin to a child with Kawasaki? Remember, aspirin is an NSAID. That's one of the things we don't think about. So Kawasaki doesn't have pain. It's more of, you don't feel well and you got a fever and a rash and whatnot. It's not pain, so it's not used for that. But it does. It prevents clots. It thins the blood and it's an NSAID. So it is an anti-inflammatory. It's an itis, vascular itis. It does help. An abnormal hole between the right and left atrium is called what? So in between the right and left side of the heart is a septum. The upper chambers are called atrium. The bottom chambers are called ventricles. If there's a hole between the upper chambers, it's an atrial septal defect or ASD. If it's the lower chambers on the ventricle, it's a ventricular septal defect. What's the treatment for a tet spell? What did I do for Nolan Ryan? That went blue on me, 5 in the morning. So again, it's a knee, chest, and remember, older children by themselves just squat right down on their legs and they take themselves out of the tet spells. A multi. Why is prostaglandins given to a child with transposition of the great arteries? What does prostaglandins do? Prostaglandins, mommy during pregnancy has it there for fetal circulation, right? After mommy's gone, we can give ourselves some synthetic prostaglandins for those conditions where you need an oxygen giver, right? So it helps with oxygen and maintains cardiac output. It has nothing to do with endocarditis, nothing at all. All it does, it keeps open that oxygen giver. That's all it does. What is the purpose of giving indomethacin to a neonate with a PDA? What does indomethacin do? So indomethacin, basically, it closes the PDA. The prostaglandins, it stops it, whatever's there. It says, nope, no more, and let's close that PDA. Transposition of the great arteries is what? What does it mean? So, transposition of the great arteries. The heart has two arteries, the aorta and the pulmonary artery. It just means they're switched. Okay? Think of it that way. When measuring blood pressures on 4 extremities of a child with coarctation of aorta, what do you expect? What is coarctation of the aorta? It's a kink in the garden hose. Blood can't go down. What happens? So, if blood can't go down to the lower extremities, blood pressures are lower. But if it can't go down, it goes up. So the upper extremities are going to be higher. And that's what you would see. I've actually saw one when I first started in the newborn ICU. I found one of them. Early signs of heart failure in infants include, you might see a weight gain, but a weight gain with this, we know something's going on. It's going to be poor feeding and sweating. Think about it. Heart failure means the heart's not beating right, which means oxygen is not going around the way it should, fluids building up in the lungs. What are going to be signs? Well, I can't eat. I have no energy. I have no oxygen. And with that, I'm working so hard, I'm sweating. That's how you got to that answer, okay? A multi. Signs of heart failure in a 3-week-old with congenital heart disease. Remember, heart failure initially is going to show a weight gain, but heart failure in the long run, because it doesn't beat well, it's going to show weight loss because the heart can't keep up with itself, okay? That's the difference between weight loss, weight gain, and I know that's a confusing concept. We know heart failure is going to start swelling because of all the increased fluid in the lungs. It's going to be tachypnea and tachycardia, hypotension, your heart can't beat, but initially it's weight gain. Then it turns into weight loss. Multi. Feeding the infant with heart failure. Heart failure. I just have no energy in the world, right? I could tire easily. I'm going to be tachypnic. I'm going to be tachycardic. How are you going to make it easy for me? So you can take the formula and you can make it higher in calories, which means they have to drink less fluid, less energy to eat, okay? Sitting straight up, that helps with it. Of course, you're going to monitor tachypnea and diaphoresis and all that because you don't want them overworking. Never, ever, ever feed a heart failure child more than 30 minutes, okay? And it's cluster care. Cluster care. We want to disturb them as little as possible and let them get the most rest they can. After a heart transplant, what's the leading reason children die? Rejection, 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 rejection. Okay? Nursing care following a cardiac catheterization. So after you have a cardiac catheterization, our biggest concern is that dressing, and it's all about bleeding. We don't want that. Keep that right leg straight, okay? You can slowly elevate the head of the bed, and they need to be on bed rest 24 hours. It's that blood clot. We want to keep it there. We don't want bleeding going on. Where's the patent ductus arteriosus? Where is our oxygen giver? Oxygen giver goes from the lungs to the body, right? Think about it very realistically. Lungs to the body. So pulmonary artery, aorta. Does that make sense now? A multi. What is a sign of digitoxicity in infants? So who puts C in yellow spots? How many infants tell you they see yellow spots? You got to be careful. Look at the questions carefully. Now, they might be a little retchy, which will show you nausea or vomiting. Yes, heart rate of 90, that is too low. And digoxin has nothing to do with infection. So it's vomiting and heart rate for infants. What are the signs and symptoms of heart failure in children? So heart failure, you're going to have fluid building up, increase in your weight, right? Also, heart palpitations, your heart's going to be fighting against all this extra fluid and shortness of breath, all the above. Which medication is usually used to relieve the spasm during TET spells? What do you think could relieve a spasm? Because that's the pulmonary artery spasms and closes off. Now, for long-term treatment, many times they're placed on digoxin, but during a TET spell, we're going to give morphine. The morphine helps them relax, and it will help them, the pulmonary artery to relax, and for blood flow to go back into the lungs. ACE inhibitor is for blood pressure. It's nothing to do with TET. Last question. Key to preventing post-op complications. The key. Which one do you think here is key? So preventing post-op complication is early ambulation. Yes, we're going to administer pain management, yes, but it's the ambulation that's going to prevent complications. Number 3, Jennifer. Good job, Jennifer. Number 2, got an A. A. Number 1, drum roll, bing. Got an H again. And number 4, Lauren and Tara, good luck. Good job, guys. So I am done with today. Know that if you came in late, I'm not counting it late today. I know it was all going on. We're going to have to figure out what to do with the quiz and what works out the best for all of us. We'll work on that at another time, okay? I appreciate the communication that I received to show me that I wasn't going crazy, that Canvas wasn't working, and that it was more global, and it helped me, and it helped other students, other professors. So thank you so much. It is a great week to start your pediatric assessment project. If you can, send me your diagnosis. Let me know what it is. If you send me your papers early, I can show you a perfect paper. So as you go onward in Fortis or in your career, you've got an APA paper you can work with, as your template. Guys, it's been a great evening. I'll see you next week. Anybody who needs anything, just let me know. I'm here.
Ms. Bogart, do you just want me to stay on?
Yes.
Okay.